afternoon, everybody. Can just adjust the mic. I'm feeling a little bit stranded because I had a co-presenter today who's not arrived yet, and she had to come from Sydney because she's been presenting at Thames. So I'm assuming that there's been some kind of a transport issue. And given that she was doing half the presentation, it's made me a little bit nervous, so bear with me. I will soldier on because I took the start and the finish, the easy parts, and she was going to do the guts, which was the harder part, but it's all on the slide, so that's the good news. But before I start, I just want to acknowledge I'm on Whadjuk Noongar Boodja. Do you feel that connection into the land and the country on which we're meeting today? And I just want to acknowledge the beautiful kinship family structures within our First Nations peoples and how they don't fit our framework, but I wish we fitted theirs, because how much enrichment could we feel within our communities with that interconnectedness. So I acknowledge today that this is their land, never ceded, that we're standing on, and I feel privileged to be here to share this message with you today and to acknowledge them. And I also want to acknowledge all of the giants that's come before me within this space, all those with lived experience of caring, whether it be mental health care specific, which we're going to be talking about today, but even the broader carer community, those that had the courage to stand up and speak and carve out a way for us to be able to share information and to be acknowledged and seen within these systems. So I just acknowledge them today. So I wear many hats. I'm a mum and I'm a wife, and in those two roles I provide care to my family members. I have 5 family members that have varying degrees of mental health challenges that go up and down over time, as you do find within mental health spaces. And it's a privilege for me to be part of that family group and to learn from them. Sometimes I felt like I had it all together, and they've let me know very clearly that I don't. And so we've been able to share this journey together, and I want to acknowledge them today as I'm sharing, because they're the reason I'm here. They give me a part of an identity which is called carer, and I embrace that identity today. I also wear a hat as Carer Peer Engagement Officer at Helping Minds. So I'm very privileged. Hello, gang over there from work. To work at Helping Minds, and it's been a wonderful opportunity for me to apply my lived experience to help improve the landscape for mental health carers, and that's enabled me to work locally, at the state level and at the national level. And at the national level, I sit on the National Mental Health Consumer and Carer Forum and wear the hat currently of Deputy Co-Chair. I've just earlier this year was in the co-chair role, but as things do, we pass that around so we don't get burnt out. And I was very grateful to hand that on to Kerry, who unfortunately is just not here just yet. I'm still hopeful. Rescue, please. So we wear many hats as carers, and I want to acknowledge you all today in your many hats that you are here today. Some of you are doing the solo caring role, and others of you are really connected into community and giving out of the goodness of your heart to improve for others. And all of those are equally valuable. Do you feel that? I want you to just to hold that in your heart right now, that whether you are purely focused on providing care or spreading your energy further abroad, it's equally as valuable. And your voice is equally as valuable, and we need to hear from you, whatever your experience is. So who got engaged in this project and how did it come to be? The National Mental Health Commission, as part of the pandemic response plan, approached organisations with some funding to do some research. And when they asked me, Hayley, what could you look at within these vulnerable people groups? I immediately said carer distress. I was curious about what's happening for carers on the ground during COVID, because I knew from what I'd heard from others who are working in the carer space that carers were distressed. And I wanted to see that. I wanted to see, what does that look like? How is it being impactful? And so we got funded we applied like everybody else and was successful for funding. We pulled together a project steering group, and fortunately Helping Minds was part of that group. And you can see all of the other community managed organisations listed up on the slide, and there were many. We had 5 members from the National Mental Health Consumer and Carer Forum. 4 of those were carers and 1 was a consumer. And then we pulled together, part of that steering group was also the National Mental Health Commission, had some representation on that. The CALLED project, which is the Embrace project. And we also invited Black Dog Institute to be part of that group. And then together, we decided who we would work with as a research team, and we selected Monash Switch Group because I'd seen Melissa Petrakis present, and I saw her heart for this work, and I wanted the opportunity for us to work with her. And so that they were the successful tenderer, and I'm so grateful for that choice because what they brought through they already had extensive knowledge of the carer space, but they brought co-design hearts to the project. So every phase of this project had lived experience, involvement, engagement, and the opportunity to shape what the survey looked like, what the focus groups looked like, what the final report said, and how that was put together, what language we chose to use, how we wanted to be really mindful of how the carer experience being so publicised would potentially have an effect on the consumer experience. So we had all of these thinking spaces as we worked together. So our process was we just co-designed our survey, our focus groups, and then we enacted that. So we did focus groups across Australia and with specialty groups, and we ran a national survey. Then we got all of that data together and we looked at it, and we went through the findings, and we came up with recommendations of what we think the Australian government could do to address this moving forward, which is the whole purpose of us doing research, was to make some recommendations. And I just want to give a trigger warning. Some of this information is distressing. It was distressing for us because we got all of the raw data and had to wade through that raw data and narrow it down. And we've tried to choose people's stories that are not as distressing, but some of it may be. So if you do feel triggered by anything you hear today, please either go and find some support. I'm sure there's some support on site, or come and see myself after the presentation, and I'm happy to have a conversation with you to make sure that you leave today not distressed. So just some stats around the focus groups. There were 7 focus groups, 73 participants. The majority were females, 53, and the ages ranged from 21 to 80 years, and it was across all of those states and territories. So what did we hear from our focus groups? There were concerns about the consumer experience. The experiences of consumers that are of concern to the family carer were the increase in psychological distress and symptoms. Obviously, that was because people left their normal routines because they couldn't access services, etc. And that closure of activities really affected people, and I know that was true for our family as services closed to respond to the pandemic. What we heard was also there were concerns about service provision. These concerns were expressed as sudden closures of services, families blocked from active engagement. An example of that is going to telehealth, one person on the phone call instead of in a room where the whole team can be together. Rigid and inconsistent application of the rules and visitation procedures. So one hospital might have a set of rules, another hospital might have different, or community, for example. And that really impacted people. Diverse experiences through differences across the lifespan. So young carers had difficulty accessing free and low-cost services. Called carers wanted more holistic models of care and reduced discrimination. And regional and rural carers had poor access to psychiatrists and psychologists with prohibitive costs and long waiting lists. There are also carer personal experiences that were distressing. The stress, depression, anxiety, feelings of suicide and losses experienced by families and carers alongside positive experiences. So we did get some positivity in this. It wasn't all gloom and despair. They felt like their world had shrunken with COVID due to the isolation and those long periods of being in lockdown. So there was that sense of a loss of what's normal. There was also the loss of work and activities outside of the home, which reduced their contact with other people, and they felt that dearly. And the relentlessness of the caring role caused a sense of hopelessness in some carers. And for some of them, that was leading to suicidality. There were increased levels of care provision. So some carers experienced a loss or reduction of support services and escalations of symptoms. Sorry, got a phone going off here that I don't need to attend to. An escalation of symptoms in the support people, and the NDIS placed added strain on family, especially where hours of services were cut abruptly. Can anyone relate to that? Okay, complexity of care provision. The increasing complexity of care, including intersectionality of multiple tasks and services, roles and navigation. So families and friends who usually provided relief were unavailable. And I think some of us could really relate to that. It was very difficult, especially where grandparents would normally step in, and there was a higher risk. So that led to a lot of isolation. And primary family carers experienced increased hours of support, supervision and care. And interestingly, some of those, or a large percentage of those, it was something like up to 40 hours additional. So it's almost double what they were doing pre-COVID. And lone carers were especially vulnerable. So the factors that led to those beneficial experiences that were reported were the NDIS providers were consistent, delivering respite and meaningful activity for the supported person where that was available. Government initiatives of financial assistance and COVID payments were a relief for some, especially if they were not really affected financially. That bit extra helped them. And listening to the family to understand their approaches. This seems like it's going to go on forever, doesn't it? Enhanced strategies and skills. The strategies and skills developed opportunities to develop and practice during COVID-19, which were things like doing some fun things with family and the supported person. So they had to rethink how they did life and needing to ensure finding time for some activities for themselves and keeping a sense of hope for self and the supported person were some of the things that they found helpful. Innovations provided that were or could be responsive to need were care support services in communities and mental health services really stepped up there to reach out, and that involved in some instances doing online for the first time to meet that need of carers where they were at, or telehealth services. Program innovations that increased connection and technology with the telehealth scene beneficially by a number of carers, but not all. As I said earlier, for some, going to telehealth cut carers out of the loop of communication, and that had a huge impact. But for others, it meant they had access to services, some regional and remote, for the first time, because there was so much risk aversion to telehealth prior to COVID. Implications for policy and practice is where the mental health system or services could make changes that could influence experiences is in the need for alternative safe space instead of hospital. That was a huge thing that was reported. They want a safe space that's not hospital-based, and that telehealth is not usable for or appropriate for many of the consumers who may have paranoia about telephones or may not even have access due to financial constraints or lack of technology skills. That the recognition of work of informal carers and the value they bring to the health system. The impact of system failure and challenges of family and carers. We already know that there are underlying gaps. So some of these things were not new, but they were definitely enhanced through COVID impacts. Service gaps deepened the level of distress that people experienced, and trying to access services for suicidal, highly distressed family members was difficult, and financial support's very difficult to access. So we also had the survey results, which had a different set of findings and some crossover as well. There was increasing levels of care. So they reported that more than half the carers supported 2 or more people. So they had a higher burden of care. And that most carers lived with the person that they supported. So there was a lack of opportunity for a break from caring. And that their caring hours on average, as we see here, increased or almost doubled during COVID. The complexity of the care most supported people who had multiple challenges, and anxiety and depression were prevalent in their care recipients that may not have been there before COVID, and providing high emotional support necessitated reduced employment for most carers, which we saw earlier in the other focus groups. So as we would understand, the breakout was the most stressful part of the COVID experience. But we did have that increase in stress earlier this year when we had a second wave and third wave of the pandemic. And quite distressing to me was the increase in domestic violence that was reported. More than 1 in 5 carers felt unsafe, afraid, controlled, or physically harmed by the person they support. And that's because for a lot of people, their normal routines were interrupted, which caused behaviours that were a reaction to that interruption. So there's no blame associated with this. It was a consequence of the circumstances. Supporting someone experiencing delusion and distressing close quarters can be very distressing. And so 1 in 3 carers needing support due to domestic violence received it. And I think that's quite alarming when you think about if you're one of the other 2 that didn't receive support, you had to soldier on alone. So other areas of interest reported by family and carers were that there was a lot of family unit distress. So that increased pressure on the whole family unit. And that could be because they couldn't get to funerals, they couldn't participate in family events, which caused added pressure. Severe and persistent fatigue is noted, and their own health and social challenges were increased. Exclusion from service settings and treatment decision-making. Family carers and the people providing high levels of mental health care during COVID were frequently not able to access services for family members in need, not included in planning and decision-making about treatment that they were then expected to monitor or enable, which we do experience outside of COVID, but it was certainly increased during COVID. And they were grateful for those occasions when specific workers included and supported them. And there was effort made from individual workers within mental health services, be that community or public sector services, to go the extra mile during COVID. So I wanted just to acknowledge their work. And respite. Respite was especially important. 3 in 4 carers were unable to join social activities. Almost 60% experienced low family life satisfaction. And respite was provided under the previous models, and that was taken out just as COVID hit. So a lot of people were no longer able to access the kinds of respites that previously kept them motivated. That connection once a year with people that had like experiences, which was really validating and helpful, had disappeared from the landscape. And final slide is about suicidality. More than 1 in 4 carers surveyed experienced suicidal thoughts. This was in the context of excessive demand work, isolation, feeling helpless and powerless. and also being in that close contact with a loved one who was distressed, threatening, or themselves suicidal. And for young carers, isolation from friends and educators, lowered energy, motivation, and interest in living. So what do we want to do? We have some short-term recommendations. We want our governments to review their practices in inpatient and other clinical settings to ensure we are included and that we are partners in that. So moving from a traditional form of care to the triangle of care where we are part of that process, communicated with. We want them to fund the creation of carer peer navigator roles so that carers are able to access services and have options. We want them to prioritise the creation of carer on-call roles so that people are available when carers actually need them to support them, not just between the 9 to 5 window, Monday to Friday. We want them to fund available and responsive mental health carer respite so that when we need it, we can actually access the respite that we do need to reduce the stress and distress. We want them to respond to current and future major disasters and create local and regional mobile centres for family assistance. And then our longer term goals are we want them to fund diverse modalities of consultations and therapeutic interventions to enable mental health consumer and carer choice. We want them to recognise the risks inherent in providing long-term and acute mental health care on carers, and to establish domestic violence services tailored and responsive to family members experiencing acute and/or cumulative risk and violence. We want them to recognise the impact of providing long-term and acute mental health care on the psychosocial wellbeing of carers, and to establish suicide preventions that are services that are responsive to those family members experiencing acute and/or cumulative stress and distress. And we want them to provide national guidance and coordination for innovation across all states in administration and guardianship. So where do we get to from here? When we started this project and did the desktop research, we found there was nothing. There was very little that we could compare our data with prior to COVID, because the carer space has had so little research dedicated to the distress of carers. We wanted data that we could use to advocate for carer respite and for these other services that we've put in the recommendations. And so what we do is we want to invite you to use this data in your advocacy work. It paints a very poor picture, but we want to see that picture changed. We want to see that shifted, and how it can be shifted is if we all speak together and we say the same things because they're the truth about our circumstance and they're solutions that we all agree to. So we present you with this data and we say use it and take it forward in your advocacy. Think about it in your service planning if you're here from a service provider. Think about it in your service planning. What are gaps that you're seeing there that your service could actually fill? And then reflect upon that. Reflect upon those situations, circumstances of the individuals that gave of their information to us, and consider how you could personally make a difference. You may not be engaged currently, but you might be the next Grow Group starter or Connect Group or some other form of support or research or financial or whatever it might be. Think about how you personally could be helping to change the landscape for carers. And finally, just be inspired to conduct your own research. I've never done research before in this kind of capacity. I've been engaged in different projects, but I found it really fascinating to just actually take a step out and do something a bit different. Thank you for listening.